Hey peeps. Today we'll be going over gestational trophoblastic neoplasia. If you didn't catch the last lecture on gestational trophoblastic disease, head over to that one first. That'll kind of give you a primer to this lecture here. So we already went over, let's get the pointer here, GTD versus GTN, the diagnosis. So in this lecture, we're going to focus on the diagnosis and management of GTN, low risk and high risk. These are the same references from the last video. I really encourage you to read these three papers. They're excellent. They will give more information than what I have given here, but hopefully I can do a nice overview. One thing that we didn't go over in the last lecture that I just wanted to touch upon here was prophylactic chemotherapy after evacuation of a mole. So should we consider it? Should we be doing it? I'd say overall, usually no. The answer is no. Unless the patient has high-risk features or barriers to getting beta HCG surveillances. There were a couple studies that did look at this and it did decrease the risk. However, we have to weigh the risk of giving a chemotherapy agent. So the short answer is usually not recommended. And before we dive in to the GTN lecture, I did want to go over just beta HCG. I think this comes up quite a bit, but the alpha subunit, so there's two subunits of HCG. There's alpha and there's beta. And the alpha subunit is the same for all the glycoproteins, so LH, FSH, TSH, while the beta subunit is unique for HCG. And you can kind of see that here. And so peri or postmenopausal patients can present with false positive HCGs resulting from HCG-like polypeptide from the pituitary gland, and this can be suppressed by OCP. So keep that in mind when you're seeing patients that sometimes you can see this crossover from the alpha subunit. And let's go over one other phenomenon, the phantom HCG. So this occurs in about 3 to 4% of patients. You'll see a low level beta HCG, and some individuals will have circulating factors in the serum like heterophile antibodies or just non-active forms of HCG that interact with the HCG antibody and cause a false positive test result. And so I really like this figure. I didn't make it, but the top shows true detection of HCG, and then the bottom shows the heterophilic antibodies attaching and showing a false positive. So in order to evaluate this, you can do serial dilution in the lab, or ask your lab to do it. But also a urine pregnancy test should be negative. So I would say that's probably your first step. The antibodies are too large to cross the renal tubule, and so they're not excreted in the urine. So think about this too, if you kind of see like a low level beta that either isn't responding to chemotherapy as expected, or there's no evidence of disease. All right, let's get to the actual point of the lecture. So we already went over this chart, GTD to GTN. Your forms of GTN: invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. We'll go over these very briefly at the end. This highly curable with chemotherapy are for the invasive mole and the choriocarcinoma. That actually does not apply to these intermediate trophoblastic tumors. Risk factors. So after uterine evacuation, local uterine invasion can occur in about 15% of patients, and a metastatic disease will occur in about 4% of patients. And so after a complete mole, these are considered to be, with a complete mole, these are high risk factors for postmolar persistent tumor. So HCG greater than 100,000, uterine size greater than dates, FIGO, lutein cysts, which I have here, and then age greater than 40. So they're kind of high risk factors to have postmolar GTN. And partial moles, there is no distinguished risk factor. Clinical presentation, main point is irregular bleeding. It really depends. Inconsistent symptoms is what you'll see on this slide. If there is metastatic disease, you may see symptoms related to that. For your intermediate trophoblastic tumors, you may see some irregular bleeding. Could see, betas, obviously, but then rarely you'll see viralization or even nephrotic syndrome. Diagnosis. I would say this may be the most important slide. You have to know this. So you're getting your betas after your evacuation of your mole, and if you see a plateau of 4 values over a 3-week period, or you see an increase of more than 10% on 3 values over a 2-week period, that's diagnostic for GTN. If the beta is detectable for more than 6 months, GTN, or if choriocarcinoma comes on your pathology. You always must rule out a new pregnancy, so just be aware of that. Once you have your diagnosis and you're going to start your evaluation for metastatic disease, you can start with a chest x-ray. If that is negative, then you'll need a chest CT. If that is negative, then there's a very high negative predictive value that there is metastatic disease anywhere else. Though I will say that I've seen people just get a CT chest, abdomen, pelvis to be certain. Oftentimes, an ultrasound is very easy to get to confirm the absence of a pregnancy. And then also it can detect myometrial invasion. Because the next step we're going to talk about, and we'll just skip right down here, if there's no extrauterine disease, should you do a repeat DNC? So we'll talk about that next. So getting an ultrasound to look at that kind of endometrial lining can be very helpful in a CT chest, abdomen, pelvis. If you do see metastatic disease in the chest, then you are going to want to get a brain MR because you can have brain mets. And then depending on what you find there, you'll move forward with either chemotherapy or you may consider surgery. This is the FIGO staging. The most important thing here is that lung mets, stage 3, is very highly tested upon because usually lung mets will be in stage 4, but for GTN, since it's so common, it is stage 3. And this is the WHO prognostic score. You will have to know this. There aren't many good ways. It's just kind of memorizing it. I would say, so the score goes from 0 to 4, and there are several factors here. Some of the more important ones for purposes of testing maybe are the site of mets, and then that again takes into account the prevalence of lung mets. So it's common, and so you don't get a high score for that. But liver, brain has a very, very high score. So kind of just being aware of the site, and then some of the other ones are a little bit self-explanatory. You just kind of have to remember what score it is. So the higher number of mets, the higher score. The higher pre-treatment HCG, the higher the score. Higher interval from pregnancy, higher the score. So I would definitely save this, look at it every once in a while, and try to memorize it. Okay, so once you have your stage and your score, you will decide what your next step is. 7 is a number here that will help you determine whether or not you're going to do a single agent chemotherapy or multi-agent chemotherapy. If it's less than 7, single agent, 7 equal to or greater than 7, you're going to do something like Emico. Let's talk about what I alluded to earlier, which is the second DNC. So you have a patient who comes in with a uterine confined disease. Can she qualify for a second DNC? And we were able to answer this question in GOG 242. So this looked at patients who had a complete or partial mole at the first DNC. They had a WHO score of 0 to 6, no evidence of metastatic disease. They underwent a second evacuation. They were looking at surgical cure, surgical response, surgical failure, and then they underwent weekly HCGs. 60 women were in the study, and surgical cure was obtained in 40% of women. 3% had a surgical response, but still needed chemo. So 40% of patients were able to avoid chemo. 1 in 60 had uterine perforation, 1 in 60 uterine hemorrhage. The important thing to note here is that when they looked at these patients who had a surgical cure, this number came from patients with a WHO score of less than 4. So yes, they looked at everyone from 0 to 6, which is in the low risk category. But when the score was 5 or 6, no patients were cured. And so NCCN did update this in the guidelines, but they did note in here that the WHO score needs to be less than 4. So you can consider a repeat DNC, and you can potentially avoid chemotherapy in those patients. If not, single agent systemic therapy, which we'll go over next. Okay, and one other point here that I just wanted to show you was in the NCCN algorithm, it has systemic agent, single agent chemotherapy. And then it has a little J by it, which says hysterectomy may be considered if there's localized disease in the uterus and is preferred where fertility preservation is not desired. So just keep that in mind. So the 2 low-risk regimens are methotrexate and actinomycin D. I have the different regimens down here, and there were a lot of studies that went over the different regimens. We're not going to go through these in detail. I think the most important thing for you to know is that these are the low-risk regimens. And so say you're on methotrexate and your HCG plateaus. You're going to want to change to the alternate regimen. So if you were on methotrexate, you'll go to dactinomycin. If you were on actinomycin D, then you'll change to methotrexate. You're going to be monitoring betas every 2 weeks at the start of each cycle. And if you notice a rapid rise in HCG, you're going to want to recalculate. You're going to want to reevaluate for metastatic disease, recalculate stage and WHO score, because you may need to move to combination chemotherapy, which we'll go to next. And that's what I just said right here. And repeat imaging at every decision point, because if this regimen isn't working and the disease progresses, then you are not on the right regimen if you're doing low risk regimen with a higher risk disease. Like we just said, you're going to monitor betas every 2 weeks at the start of each cycle. And then if once it normalizes, that's what you would expect, then you're going to continue for 2 or 3 treatment cycles. I will say that I just referenced this paper down here, which talks about the 2 versus 3 cycles. Relapse rates were higher in patients treated with 2 consolidations of consolidation courses is what we call it. After your beta has normalized and you're continuing a chemotherapy, they're called consolidation chemo. And so patients who were treated with 2 cycles as opposed to 3 had higher relapse rates. So just keep that in mind, but it's a discussion with your patient. NCCN does say 2 or 3. And then you're going to continue betas for 12 months, and you're going to stress the importance of contraception during that time. Same thing. Okay, so let's move on to the high-risk regimen. So you calculated your WHO score. It was greater than 7. And so you're going to recommend Emico. So that's etoposide, methotrexate, dactinomycin, cyclophosphamide, and vincristine. The vincristine is an O because the other name for vincristine is oncovin. And so you'll just have to know that the other name is oncovin. And so this is every 14 days, again, until the beta normalizes, and then you continue with consolidation chemo. Here are the doses here if you're interested. Other things to note, if you've noted that there are brain mets, you'll want to consider whole brain radiation or intrathecal methotrexate or increasing your dose of methotrexate. Those are all things that you want to look into. We talked about the HCG monitoring. We talked about the consolidation chemo. And then here are some other regimens if there's not a good response or if there's a plateau. There's also, which we won't go over here, but something called induction chemotherapy for someone who has a very, very high WHO score. Then you're going to want to use induction chemotherapy to decrease the risk of hemorrhage in these patients. So one other thing for you to read about if you are administering chemotherapy, or even if you want to learn more, that'd be something for you to go read. And last but not least, we're going to just briefly touch on these intermediate trophoblastic tumors, placental and epithelioid trophoblastic tumors. They behave very differently from choriocarcinomas and invasive moles. They're managed differently. They're not chemosensitive. These are very rare. They do typically follow a non-molar gestation. The placental site trophoblastic tumors, they stain positive for this human placental lactogen. So sometimes that can be an identifying marker. You will generally see low beta HCG levels, and these are different than a choriocarcinoma as they are derived from intermediate trophoblasts. And then epithelioid is a very rare variant, and this can present many years after a term delivery. Management for these is not based on the WHO score, and surgery is mainstay because these are much less chemosensitive or chemo-resistant. And so in a stage 1, you're going to do a hysterectomy with a pelvic lymph node biopsy because nodal mets are around 5 to 15% in these tumors. Always assess for risk factors, and then you're going to monitor with HCGs if this was a marker, with PET scans every 6 to 12 months. If it's non-metastatic, there's an excellent rate of survival. In metastatic disease, you're still going to move forward with a hysterectomy because they're less chemosensitive with excision of metastatic disease, so almost like a debulking. And then you'll consider chemotherapy for these patients using HCG as a marker if it was a marker. We won't go in the nitty-gritty details of this, but I can point you in the right direction if you need more information. So that was a lot, but take-home points: contraception immediately. This was from the first lecture, but still important to hammer home. Always keep GTN in your differential if a patient presents with bleeding postpartum or post-abortion. Do not biopsy suspected vaginal mets. They will bleed or hemorrhage if this was from a choriocarcinoma, GTN. And then refer early if you are not familiar or you don't treat a lot of GTN, then refer these to your most local GTN center for patients to get the best care. So thank you for listening. I hope that you learned a bit, and let me know what questions that you have. Take care.